Okay, let's get going, guys. This is our last Cancer Center Grand Rounds for the month of April, and we have two speakers today, two speakers from our faculty. The first is Dr. Steve Bernstein, who's a professor of emergency medicine, a member of the Cancer Prevention and Control Program, who will be talking to us about tobacco control in the hospital emergency department, and then we'll be hearing from Veronica Chang as our second speaker. Dr. Bernstein.
Thank you, Tom. The volume's okay for this? Okay, good. Thanks. So I want to speak to you today about tobacco control in the emergency department, which is where I work clinically. I have no disclosures for this talk. I'd like to do two things in the time that we have. One is to talk a little bit about the epidemiology of tobacco use among emergency department patients, and then to show you the results of some work that we've done to design interventions to identify and begin treatment for tobacco dependence for people who come to the emergency department, which is sort of a non-traditional place to do this kind of work. A little bit about how I became interested in this. I initially trained in internal medicine and, in fact, hematology and oncology. Left that to retrain in emergency medicine for a variety of reasons. When I went into the emergency department, I saw a lot of presentations related to these things, these sort of leading causes of death, proximate causes of death in the United States. And they were fairly obvious: car crashes, interpersonal violence, intoxication from various substances, particularly alcohol, of course. But I was also seeing a lot of disease related to tobacco use, either caused by smoking or exacerbated by smoking. Obvious things like COPD exacerbations and asthma, myocardial infarctions, etc. At that time, about 25 years ago, we were starting to think about the emergency department as a clinical laboratory to design interventions, brief interventions for people with risky health behaviors, initially focusing on alcohol. We weren't, and a little bit on interpersonal violence and sexual behavior also in the early years of HIV. We weren't doing anything at all with tobacco, not a thing, and I thought that might be an opportunity for me, both a clinical opportunity and an academic opportunity. And that's when I started my work. Some of the earliest work was really just to define the epidemiology, the prevalence of tobacco use in ED populations. In fact, it was quite high. That's probably no surprise to this group. Our patients engage in all kinds of risky health behaviors more than the general population. The prevalence of tobacco use, oftentimes twice that of the general population of the U.S. In the pediatric ED, similarly, parents of caregivers, parents of kids in the ED, also with high rates of prevalence, high rates of smoking. That's work done by Melinda Mojave-Gittins out at Cincinnati Children's. And some early work I did using attributable risk modeling back in New York. About 5% of our visits and nearly 7% of admissions and 10% of our charges directly attributable to tobacco. So really a substantial burden of disease and cost in the ED. Why else look at the ED? So the ED is really a safety net facility. In some ways, it's the safety net of the safety net. Our volumes are growing aggressively, about 25% growth in this country over the past 25 years. That's visit volume. 129 million visits in 2010, which is the last year we have data available. Our patients are disproportionately from the lower end of the socioeconomic spectrum, but by no means should you think that all ED patients are impoverished. We treat everybody, actually by federal law, we have to do that. But we have a disproportionate proportion of underinsured and uninsured people. Often these people, of course, have little to no access to primary care. So the ED might be not only a good opportunity, but the best opportunity to engage them in a conversation and an intervention about their health behaviors. ED patients often live in neighborhoods where they receive mixed messages about health, right? So this kind of advertising and so forth. And this is from the Bronx, New York, where I used to work. And so I became interested in whether there are disparities in access to treatment as a function of socioeconomic status. And might that speak, again, to use the ED as a place to do interventions. We surveyed all the pharmacies, a sample of 30% of all the pharmacies, retail pharmacies in New York City some years ago. And we stratified the pharmacies by the socioeconomic characteristics of the neighborhood in which they are located. We basically drew a quarter-mile radius around each pharmacy and using GIS modeling, looked at census data for income, education, race, et cetera. And we found that pharmacies located in wealthier neighborhoods were more likely to stock nicotine replacement therapy than pharmacies in poor neighborhoods. And the pharmacies in the wealthier neighborhoods, the NRT was cheaper, actually. Cheaper to buy. So we thought that this, again, indicated a certain disparity in access to treatment, at least pharmacologic treatment for tobacco use, that might speak to finding alternative strategies to treat lower income smokers. Well, what happens if somebody does go to the primary care physician anyway? He or she certainly has the opportunity to treat tobacco use. That's true. But it turns out it doesn't happen that often. This is another study we did, published last year, that looked at the odds of a smoker getting a prescription or behavioral intervention for his or her for smoking in a doctor's office, an outpatient visit, compared to the odds of somebody with one of these conditions getting a prescription for any of those diseases. So basically, in an adjusted model, somebody with hypertension, the odds of them getting a prescription for their hypertension are 32 times greater than that of a smoker with tobacco use as the reference group. A diabetic has 20 times greater odds of getting prescription for diabetes than does a smoker, in other words, than a smoker getting NRT. So although we like to think of smoking now as a chronic disease, I'm trying to reframe it that way, chronic disease, chronic relapsing disease, we don't really treat it that way in the outpatient side. 4% of all outpatient visits for smokers resulted in a prescription for a medication to treat tobacco dependence. So the primary care office is a good idea, but it doesn't happen that often. Are there models that we can adapt in the ED? Well, there is. So there's something, it's got an unwieldy acronym, Screening, Brief Intervention, and Referral to Treatment. We call it SBIRT. Developed about 20 years ago. It employs principles of motivational interviewing. You can do this briefly, 5 minutes, 10 minutes, even 3 minutes sometimes, to engage somebody who has a risky health behavior, to initiate a conversation with them about their behavior and get them to think about the pros and cons of changing. You do it in a neutral, sort of empathic, non-judgmental way with referral for aftercare. This model was initially developed for people with hazardous or harmful drinking. A lot of the work was done here at Yale by Gail D'Onofrio, and Gail's been able to show statistically and clinically significant reductions in drinking up to 1 year out after an SBIRT event in the emergency department for people with hazardous or harmful drinking. It's been endorsed by SAMHSA and a number of professional societies. In fact, to be certified as a level 1 trauma center, you have to offer alcohol SBIRT for people who come in with injuries related to alcohol. So this seemed like a pretty good model for me to use to adapt for smokers. And that's what I decided to do. But we also have a lot of good medications, right, to treat smokers with. And 7 FDA-approved medications, 5 of which are different forms of nicotine replacement. So I figured I would use the 2 most common forms of NRT, patches and gum, and counseling, both in-person counseling, that motivational interviewing SBIRT model, as well as the quitline. There's this national number, 1-800-QUIT-NOW, this toll-free number that any smoker can call and get counseling and often free medications, et cetera. Every state has one, Canada. Maybe I could adapt this model, counseling plus medication, to design an intervention that would get smokers to quit. But I first needed to know if I could get the doctors to do this, the providers, because this is really not part of what emergency medicine does. We like to treat acute illness and injury and move the patient on, either upstairs or out, and move on to the next case. This is a very different model of practice for emergency physicians. So could we get them to do it? So we did an 8-hospital study a few years ago, very simple before and after study, an educational intervention of doctors at these sites. We just gave them a 1-hour lecture about tobacco use, and then we put some wallet cards in the emergency department given to us by a group of the Robert Johnson Foundation. We put these wallet cards in the ED, And we just surveyed the doctors before and after, their knowledge, attitudes, and behaviors around tobacco interventions in the emergency department. These were all emergency medicine doctors. But we also wanted patient-level outcomes, too. We couldn't do quitting. We weren't resourced to do that. But we decided to interview patients as well to see if they would confirm that the doctor's behavior changed. So we interviewed patients at each site before the lecture and after the lecture. We recruited 1,100 patients from these sites. The demographics you see there, again, largely an uninsured or Medicaid population, not, two-thirds high school or less. Most with some modest level of motivation to quit. And provider behavior did change. I'll just show you some of the more salient results. This was self-report. The doctors reported that they went from 43% counseling before we trained them to 75% afterwards. But when we talk to the patients, of course, the numbers are more modest, but there's still a change. The patients do report an important change in provider counseling after we did the intervention. And 28% of the smokers reported getting a wallet card. So, a modest effect, but it's real. But at least it showed that this was feasible to do in the ED. And interestingly, we recorded the ICD-9 codes for these 1,100 patients, and the people who had something that seemed potentially tobacco-related were much more likely to get an intervention. So maybe the doctors were targeting the patients at highest risk, and you can understand that.
Steve, will ICD-10 make this research not valid anymore?
No, I hope not. No. Try not to think about it. So that was just a before and after trial of an educational intervention. That's nice, but what about a randomized trial where we use patient-level outcomes, i.e. cessation? So I did my first randomized trial, again, back in the Bronx, Montefiore, some years ago now. We recruited 340 smokers. This was a 2-arm trial, 1-to-1 randomization, age 21 and up, adults only. These were people who were going home. They were not sick enough to be admitted. The control arm got a brochure that just talked about the hazards of smoking. It had the number for the quitline. We did it in English and Spanish. The intervention arm got that brochure, got a 10 to 15-minute motivational interview by a trained interventionist, not by the doctor on duty, by a trained person, master's level person. We gave them 6 weeks of patches. We gave them a little shopping bag. We put the patches right in their hands. And we called them up at day 3, a little booster call, with the primary endpoint being 3-month cessation, biochemically confirmed. That was our brochure. The demographics of the study, again, this was in the Bronx, so a largely Hispanic community, mostly a Medicaid population, Medicaid and self-pay accounting for more than half of our subjects. And this is typical for pretty much any of this kind of work that you do in the emergency department. Relatively heavy smokers with moderate to high levels of nicotine addiction as measured by the Fagerstrom score. And they were relatively highly motivated. We screened out people who were not motivated to quit. The study was negative. Disappointing. But what was interesting to me, a couple things. The quit rate in the intervention arm was about what I expected. The intervention rate in the control arm was much higher than I thought it was going. We thought it would be about 3-4%, something like that, based on earlier work. And what I found, and a number of investigators have found in general in trials of behavioral interventions for things like smoking and drinking, is the control arm often does a lot better than you think it's going to do, for probably a variety of reasons for that. One of which simply might be that your battery of intake assessments may itself constitute a type of intervention. Just talking to the subject about their drinking or their smoking may provoke a behavior change. So this was, the primary endpoint was negative. We had some pre-specified secondary endpoints that were positive. So people who were in the ED, because of a tobacco-related ICD-9 code, were much more likely to quit. Similarly, people who thought they were in the ED for a tobacco-related problem were more likely to quit. So I'm thinking in terms of the health beliefs model, around behavior change. So some of these subgroups did seem like the intervention worked. So maybe the idea is that you can't do tobacco control for everybody in the ED. Maybe you need to limit it to people who present with a tobacco-related problem or think they have a tobacco-related problem. So those were the things I was thinking about when I came here to Yale now a little over 5 years ago. And we did our next trial of an ED-based intervention. We took that model from the first study, but we souped it up even more. The control arm got another kind of brochure that has the phone number for the quitline, Connecticut Smokers Quitline. And this time we tweaked it a little bit. So everybody still in the intervention still got a motivational interview by a trained person. This time we did combination pharmacotherapy because we know that that is synergistic. In general, combination pharmacotherapy is more effective than monotherapy, mostly because the patch can simply replace a basal level of nicotine, but the person can still have cravings. That's still pretty common, go through some cravings and withdrawal. So if you give them something that crosses a blood-brain barrier pretty quickly, like gum or nicotine nasal spray, you can ablate the cravings. So we gave them patch and gum in this study. We didn't just give it to them. We started it in the ED. We actually put the first patch on them or gave them the first dose of gum in the emergency department. We didn't only give them the brochure for the quitline with the number. We actually faxed a referral to the quitline. So the quitline would already have their information by the time the patient left and could reach out to them. So what we call facilitated referral or proactive referral. And we still gave them the booster call at 3 days. This study targeted only low-income smokers, which we define as Medicaid or self-pay, because the RFA that we responded to targeted low-income smokers. So our proxy was everybody was Medicaid or self-pay in this study done in our ED right here. So this represents really a shift in the traditional paradigm of tobacco dependence treatment. Usually you screen people for readiness to quit using various kinds of motivational ladders and tools like this. We didn't do that. We figured if they're willing to sign informed consent, that's good enough for us. We didn't do a formal assessment of readiness to quit. We did not set a quit date. In the traditional model, you set a quit date 2 weeks, 3 weeks, 4 weeks after you first meet the patient, and then maybe they fade their nicotine. We didn't do that. We started it right then and there. We started the pharmacotherapy right then and there to show them that it was feasible to do. It's safe. It's not a problem. We made up a name for this model as opposed to that SBIRT, screening, brief intervention, referral to treatment. We call it STIR, screening, treatment, initiation. So we start the treatment right there. We've now done this model for tobacco. We've also done it for opioid addiction. We just finished a trial of buprenorphine for people with opioid dependence that was also positive, and we're hoping to do a study for alcohol dependence with naltrexone shortly, and we're going to write up a concept paper and talk about this model, STIR. We finished recruitment a while ago, almost 800 patients. Again, the demographics, you can see a pretty nice mix of ethnic and racial groups, about half a pack a day. That's pretty consistent through all these studies. Again, everybody is Medicaid or self-pay. This study was positive. So again, the primary endpoint is biochemically confirmed abstinence at 3 months. We had a strongly positive result. In fact, we made exactly what we thought our delta was going to be. We did follow these people up to 1 year out. And at 1 year, it just missed significance because there was some regression to relapse to smoking in this group. Part of what we did this time, by the way, was a much more modest intake assessment. It was probably 10 minutes worth of questions, very quick. The quitline was a big part of this study. Over half the subjects in the intervention arm used the quitline. We found a dose-response relationship between use of quitline services and probability of being abstinent, probability of quitting at 3 months. We don't really know what the direction of the association is with this. It may be that the quitline does a nice job in motivating people to quit. It may simply be that the kind of person who's going to call the quitline, more than once is also the kind of person who's going to quit anyway. We don't know, but certainly the vendor for the Connecticut quitline is very happy about this result that we also reported in February. One last bit of data from this study that I'll share with you. Again, these were low-income smokers. From some other work we did, we know that most of these folks only live off their cell phones as their sole means of communication. My research staff noticed that it seemed more difficult to reach these subjects for follow-up later in the month, any month. And they thought maybe that just reflected the fact that people's cell plans were running out of minutes and they didn't have the funds to replenish their minutes. So we decided to study that because we have logs of all the calls that are made and we know whether or not the call successfully reached the subject. So we modeled the month into 4 weeks or 4 equal periods, and using week 4 as the reference week. In fact, that's true. We found this more or less monotonic decrease in the odds of reaching a low-income smoker as the month goes on. This is this many subjects, over 2,000 calls. So we think this has some nice implications maybe for doing how you do clinical research and follow-up in low-income populations. Maybe you need to front-load your follow-up calls earlier in the month. And that's something that we're looking at in our own work. So next step, so that study was positive. That's nice, but it's not particularly generalizable, right? Because we have lots of staff to do the interventions and so forth. So there are 4,000 emergency departments across the country. How are you going to get them to do this? You don't have people to do motivational interviews. So NCI did develop a texting program, and we've become a lot more interested in the use of mobile health technologies to promote behavior change. We are now working with NCI, and we're going to start a pilot study of the smoke-free text program this week, I hope, actually, in our ED here. A small pilot just to get an effect size to power a larger trial that hopefully we'll be doing in a year or so. And in this study, we're still going to give people nicotine replacement therapy as well, but we're not going to get the motivational interview. So much more cheaper, economically efficient way to do this kind of work. So I think, to conclude, interventions are possible in ED populations. They can be efficacious, although they seem to be pretty resource intensive. So that's something that we need to think about, is how do you do this type of work in under-resourced environments. And again, linkages to aftercare, things like quitlines, smoking cessation services, like we have here at Milo, primary care are critical. One last project I'll leave you with, we're doing some work on the inpatient side now, not the ED, the inpatients at Yale, trying to leverage EPIC and the power of information technology this way. We're doing a randomized trial of a tobacco order set with some decision support where we're actually randomizing physicians, randomizing 200 docs on the inpatient side. Half of them see this and half don't. And we're going to follow their patients up to a year out and see if this can promote greater smoking cessation among the patients who are exposed to doctors who have access to this order set. That study's ongoing. I just want to thank my wonderful collaborators here at Yale, elsewhere, and the agencies that have made this work possible.